Thanks again for the invitation and thanks for the introduction, Jeff. My name is Joe. I'm an anaesthesia and ITU doctor working at the QE in Birmingham, and I'm a member of the AI and Digital Health Research and Policy Group with Jeff and colleagues. And I'd like to just have a few minutes talking to you today about predictive clinical decision support tools. I guess the first question is, what are these tools? I'm aware that there's a blend of different professionals on the call today, and many with clinical backgrounds, but perhaps some without. So just so we're all on the same page, what I mean by a predictive clinical decision support tool is any tool that lets a clinician use data to add to background knowledge and gestalt and expertise when making predictions. And those predictions can be either diagnostic, prognostic, or for other purposes. And there's a bit of background as to how these tools come about. Well, they've been around for decades. So the first kind of tools emerged in the 1970s. They're often created by individual researchers or small research teams. And normally the way they exist is as a research paper. So it's published in a journal and it will then be adopted into use, perhaps. Some of them are created by larger consortia. So a good example of that is QRisk, which is produced by an Oxford team. And also external companies sometimes produce these tools. But normally they're produced using research data or data that's available through electronic health records and then published as papers, as I said. And one of the reasons I'm talking today is because there's an interesting crossover with predictive clinical decision support tools, artificial intelligence with the medical device, and therefore need for regulatory marking, which I'll touch on a bit later. In terms of how they work, I've got a couple of examples from my sphere of medicine, which is perioperative care. So one example is the ASA score, which is a simple ordinal score from 1 to 5, where healthy, fit and normal patients are scored 1, patients who are unlikely to survive score a 5, and people who are somewhere in between get a different number. And the reason that this score matters is because depending on the score someone gets, you might treat them differently. So as an example, if someone's ASA scored a 2 or a 3, that might prompt them being treated in a different kind of hospital. Maybe they're referred to a specialist centre rather than a general day case centre. So that's just one example of a very simple score. A more complex example would be the SORT score, which stands for Surgical Outcomes Risk Tool. Now, this takes in lots of data around a patient's operation, their current health status, and then uses that with a logistic regression equation to try and predict their risk of dying within the next 30 days after an operation. Now, interestingly, this tool is published as a paper, yes, but also provided by the authors as a web app. So anyone can go onto the internet and compute the score, as you can see in the little video that's playing, and it will give you then the predicted risk of mortality of, in this case, 2.68%. So this is a blend of both the actual research paper and an online tool to operationalize it. In terms of how they might be used, well, across the entire perioperative example that I'm giving, well, we can have primary care uses of these tools where GPs might use them to help make a diagnosis or to classify severity of disease. Teams in hospitals might use them to work out if surgery is the right option. When the surgery is actually happening, well, the surgeons and anaesthetists might use them to decide how to operate. And then in the recovery phase, the type of ward the patient goes to or when they're discharged might vary according to the output of various scores. And the reason I think this is important is because there's just been a massive explosion of these tools over the last few decades. So this graph on the left shows just a simple paper which is talking about the expansion of PubMed searches, PubMed articles relating to clinical scoring systems. And you can see around the 1990s there's a massive upward inflection. And now we're seeing about 2% of all papers published in the entire medical corpus relating in some regard to these tools. And some of my own work from earlier this year has found that in perioperative medicine in just the UK, there are 87 different models, scores, and other tools used by professionals, which I think is a staggering number. That's more than the drugs that are on, the formulary probably for anaesthesia, which is just, I think, crazy, really. And that's just one very small subsection of the overall health practice. And this would all be fine if it wasn't for the fact that there's significant methodological concerns around these tools. So statisticians and methodologists for the last few decades have been raising alarm bells around the fact that in many cases, the statistics underpinning these tools are just not up to scratch. So things like the way that the tool's been designed and the way it's been evaluated means we shouldn't have much trust, I guess, in the validity of the results. And yet these are widely used. Some other problems that I've come across in the actual development phase, well, many of the tools take in some sort of subjective data input. So they ask the clinician to make a subjective assessment and then use that to modify the risk. And there are other examples where tools might talk about old phenomena in medicine. So example on the right here of a data shift where the tool asks you to input whether someone has SIRS, sepsis or septic shock. But this is old terminology. And now we have new terminology in terms of severe sepsis and septic shock. SIRS is no longer a classification used in actual diagnosis. And to kind of add insult to injury, This graph is quite a lot of information on it, but what this basically shows is that from some of my own survey data, not only are these tools very widely used, but we actually are very bad at telling patients about when we've used them. So you can take kind of blue as being pretty good, which is basically that you always, or in most cases, tell patients that you've used it on the left-hand side, and pink or red as being not that great. And you can see that across the 18 most widely used scores in perioperative practice in the UK, we're actually pretty bad at telling patients that we've computed them. And yet we know these scores have high influence over the care we provide. We're slightly better at recording the results in patients' notes, but still not 100% perfect for all the tools. And then in terms of that influence, well, this graph shows the 18 most widely used scores and their degree of influence. So the dark blue is high degree of influence, the light blue is moderate influence, and the grey is low or no influence. And you can see for these 18 different tools, all of them have high or moderate influence for the majority of respondents, which I think is important. And Jeff mentioned about the gaps in kind of regulation of these tools. And I think these are a really interesting phenomena because most aspects of healthcare are regulated in some regard. Obviously the overall delivery of healthcare is a series of pathways, and at the system level is regulated by the Care Quality Commission, and I guess to some extent commissioned by NHS, England, Scotland, Wales, etc. And clinical judgment, so clinicians' own practice, is regulated by their professional regulator, which might be the GMC or the NMC, etc. And then if we think about clinical criteria and simple treatment guidelines, things like how we actually define and treat and diagnose diseases, well, these are the purview of NICE, of professional royal colleges, learned bodies, etc. So that's a kind of regulation, or quality control at least. And then at the other end of the complexity spectrum, on the bottom of this slide, you can see artificial intelligence. Well, that is regulated as a medical device formally, so it's under the purview of the MHRA, and there's strict AI and the software as medical device regulations to adhere to. I think the slight grey zone is in the middle, really, which is the clinical scores and predictive models I've been talking about for the last kind of few minutes. Because I don't think these tools are sufficiently regulated. Some of them may fall under the purview of medical device regulations in the UK, depending on how you define a medical device. But there's actually very little clarity here as to which of them should be under the regulations and actually how we would go about operationalizing that, if that were to be true. So I guess kind of bringing us into land, my key concern is that these tools kind of fall through the cracks in the current systems of oversight we have for data-driven technologies in the health service. I think there's problems with the quality of evidence. I think many tools are just simply not auditable because they have subjective data inputs, or the data they ask for are not available in electronic health records. Many of them may have relevance when it comes to software as a medical device regulations, but we don't really know how that applies. And there's limited transparency about how these tools are actually used. So we're not very good at recording when we use them or telling patients how they've influenced their care. So I guess putting this all together, my main question is, well, how do we make this better? How do we improve the current system of oversight for these tools so we can ensure that they're safe in use, and also the future tools are most appropriate? And I don't want to take any more of your time, but the long story short is that's the subject of my PhD, and hopefully in the next year or two, I'll be able to give a report back on that, answer to that question. Thanks very much. I'm going to stop sharing and happy to take any questions.